Hey everyone, all you brilliant MBBS students and junior doctors, listen up. In the next 5 minutes, we're going to make you absolute pros at heart blocks. I promise. After this, chahe exams ho ya ICU rounds, you'll spot them like a hawk and know exactly what to do. So ready? Let's jump right in. Alright, so here's the plan for today. We'll start with the basics, the heart's electrical highway. Then we'll look at the chill ones, the slow lane blocks. After that, things get serious in the danger zone. We'll decode those tricky bundle branch blocks, give you a solid ICU action plan, and wrap it all up with an exam summary that is pure gold. Let's do this.
Okay, first things first, let's talk basics. Imagine the heart's conduction system is like a super efficient electrical highway. The journey starts at the SA node. That's the heart's own natural pacemaker, right? From there, the signal zips over to the AV node. Now, the AV node is super important. It's like a traffic light, creating a tiny, super crucial delay. Why? So the ventricles have enough time to fill up with blood. Once that's done, boom, the signal shoots down the Pacemaker system, and that's what gives you that strong heartbeat. That's the normal path. A heart block? Well, that's just a roadblock somewhere on this highway.
So, what exactly is a heart block? Super simple. It's basically a traffic jam on that electrical highway we just talked about. The electrical signal, which you see as the P wave from the atria, either gets delayed or just completely fails to reach the ventricles. You know, the guys responsible for the QRS complex. That's it, a communication breakdown.
All right, let's talk about our first type of block. I call these the slow lane blocks. You know, the ones you definitely need to recognize, but you don't really have to hit the panic button when you see them.
Okay, first on our list is first-degree AV block. Listen, the only thing you need to look for here is a long PR interval. Anything over 200 milliseconds or more than one big box on the ECG paper. But here's the key. Every single P wave, every P wave, is followed by a QRS. The signal always makes it through, it's just taking its sweet time. You see this a lot in athletes, actually. So the bottom line, PR interval thoralumbei, but tension nailani. No treatment needed. Simple as that. Next, we've got the famous Wenkebach, or Mobitz type 1. This one has a classic personality. Think of the AV node as getting sleepy. It's getting tired. So with each beat, the PR interval gets a little bit longer, then even longer, until finally it just gives up and poof, the QRS is dropped. The signal doesn't get through. So what do you need to remember? Just this, longer, drop. That's the rhythm. It's predictable, which is why it's usually not a huge deal.
Okay, deep breath everyone. We're done with the slow lane. It's time to enter the danger zone. These are the blocks you absolutely cannot ignore. These are the ones that can be unstable, clinically significant, and mean you have to act and act fast.
Now, this is a tale of two very different blocks. On one side, you have our predictable friend Wenkebach. The problem there is high up in the AV node. It gives you a warning, right? That longer drop. But then, you have the villain of our story, Mobitz type 2. Here, the problem is way down in the Pacemaker system, and this is what makes it so scary. Look at the PR interval. It's perfectly constant, marching along just fine, and then, bam, out of nowhere, a QRS is dropped. No warning whatsoever. It's McGoy warning nahi sida drop. This is a massive red flag, because this guy can turn into a complete heart block in a heartbeat.
And that brings us to the final boss, the big one, third degree or complete heart block. Look, the communication line between the atria and the ventricles, it's gone. Completely cut. The P waves are doing their own thing, and the QRS complexes are doing their own thing. They are totally independent. The best way to think about it, the atria and ventricles are in a messy divorce. And the ventricles, well, they're left to fend for themselves, using a really slow and totally unreliable backup rhythm.
And just how slow is this backup rhythm? We're talking dangerously slow, like 20 to 40 beats per minute. Think about that. That is nowhere near enough to pump blood to the brain. And that's exactly why these patients get dizzy, they pass out. That's what we call Stokes-Adams attacks, and they can go into full-blown shock. Make no mistake, this is a real deal medical emergency.
Okay, so everything we've talked about until now has been about blocks between the atria and ventricles. Now let's switch gears and talk about blocks happening within the ventricles themselves. These are the bundle branch blocks, and you gotta watch out for these, because they can be sneaky little curveballs on an ECG, sometimes hiding much bigger problems.
So how do you nail these in an exam or on the wards?
Easy. We've got some killer English mnemonics for you. Ready? For a right bundle branch block, or RBBB, you look at lead V1. What you're looking for is an M shape. Kind of looks like rabbit ears, right? So the mnemonic is simple. Right में rabbit ears. V1 देखो, अगर M shape दिखे तो right का problem है. Easy. Now for left bundle branch block, LBBB, you need to look at V1 and V6. In V1, you'll see a deep W shape. In V6, a broad M shape. So what's the mnemonic? Left में WM. See? Simple, visual, and absolutely clutch for your exams. Okay, everybody lean in for this one, because this is probably one of the most important things you'll hear today. A new LBBB is always a big deal. Why? I'll tell you why. Because the weird way the ventricles depolarize in LBBB, it can completely hide the classic ST elevation of a heart attack. It's like a smokescreen for an MI on the ECG. It's been called a murderer of a diagnosis for a reason. You must take a new LBB very, very seriously. All right, enough theory, let's get practical. Let's put you in the hot seat. You're in the ICU, it's the middle of the night, your patient is bradycardic and they're symptomatic. They're feeling dizzy, their BP is dropping like a stone. What do? What's your move? This is your action plan.
Okay, here's the algorithm burned into your brain. Step 1, always, atropine. Push it. It's fast. If that doesn't work, if your patient isn't responding, you move to step 2 immediately. You're going to start a dopamine or an epinephrine drip. Let's drive that heart rate up chemically. Still unstable? No time to waste. Step 3, transcutaneous pacing. Get those pads on stat and be ready to externally pace that heart. This isn't just a flowchart, it's a life-saving algorithm.
But hold on a second, before you go straight to pacing, you have to be a smart clinician, a detective. Always ask yourself, why is this happening? Could there be a reversible cause? You got to check their meds. Are they on beta blockers? Calcium channel blockers? Is it the dreaded digoxin toxicity? Is your patient hypoxic? What about their thyroid? Or a crazy electrolyte imbalance, especially potassium? And never ever forget to look for an underlying MI. Always hunt for the cause. And speaking of drugs, I need to put a giant red flag on this one. If you even suspect digoxin toxicity is the culprit behind the heart block, do not try to be a hero. This is not something you manage by yourself. Your first and only move is to get a senior cardiology consult immediately. It has a very specific treatment, and any delay can be fatal. So what's the rule? Escalate early, escalate fast. Whew. Okay, we've gone through a ton of info, so let's boil it all down. This next slide, this is the money slide. This is your ultimate cheat sheet for NEET-PG, for INICET, for your final prof exams. Everything you need to know for those MCQs is coming up right now. Okay, let's drill this home. Mobitz II, the one with the sudden, unpredictable drop, that's unstable. Does it need urgent pacing? A big, fat yes. Third degree block, the total divorce, that's an emergency. Pacing? Absolutely yes. Now, LBBB. Remember the WM pattern. Pacing isn't the first thought, but you have to rule out a hidden MI. And what about our chill friends in the slow lane? Wenckebach and first degree? Nope, no urgent pacing needed. You can usually just observe. This cable, my friends, is your ticket to smashing those exam questions.
All right, let's leave you with this scenario. It's 3 in the morning. You're on your rounds. You look at the monitor and you see a brand new Mobitz II block on your patient's ECG. They seem stable for now. What is your very first call? Who do you call? What do you do? Think about it, because now you have the knowledge to make the right call.